So thank you for the introduction, Jeff. As introduced by Jeff, my name is Henry Sawe. I'm a physician based in Dar es Salaam, Tanzania, and I was GloCal Fellow in 2014-2015. And throughout my journey as a clinical researcher, there's one thing that I've grown to learn that works very well in low and middle-income countries. And today's talk, I want to focus on that particular aspect with a specific example on the projects that we're doing here. If you could do the next slide, please.
Sorry, Dr. Sawe, I think we can hear you echoing from the phone as well as the computer.
Yes.
Do you mind if I just turn off the computer?
Correct. Just do that. Can you hear me better?
Yes, this is much better.
Thank you. So the next slide, please. So a bit about my personal background. I graduated medicine from Muhimbili University of Health and Allied Sciences, which is here in Dar es Salaam, Tanzania, and went on to do double masters of medicine, focusing on emergency medicine, and also did masters of business administration in corporate management with focus on hospital administration. I'm currently pursuing a PhD in emergency medicine at the University of Cape Town, South Africa. And as pointed out, as a GloCal Fellow for the year 2014-2015, and I'm now currently the GloCal Fellowship Site Coordinator here in Dar es Salaam. My current research interest is mainly on trauma, emergency care systems, and acute presentation of chronic illness, with specific interest in sickle cell diseases and HIV. Next slide, please. So today, I want to talk to you about building the research capacity in low-income countries, and specific focus on Tanzania, which is on the eastern coast. And you'll see in the next slide that Tanzania is a country of 50 million people with a life expectancy of 52. It's slightly risen there, and HIV prevalence of 5.2%. HIV is still the leading cause of death in all age population. I'm based in Dar es Salaam, which is on the eastern coast. Next slide. And most of the research we do originates from the main national hospital, the Muhimbili Hospital, which is where I'm going to talk about my talk for today. Next slide. So as the title of my project and also title of my talk today is how to be able to come in low-income country like Tanzania and do research that is both sustainable for the local, but also sustainable for you as a fellow or a scholar in long run. Over the last 10 years, I've been receiving a good number of scholars, fellows, and senior researchers coming in Tanzania to do different kind of research, especially in emergency medicine. I must take you to the background a little bit that emergency medicine is still very new in Tanzania. It's just been 9 years since the inception of the program that I am at, and we still have my program, emergency medicine, as the only program in the entire country. And so we have a lot of interest groups coming into the different kind of research projects. And since the local capacity has not really grown up very much compared to other fields, to say like internal medicine and other different fields, most of the regional research were kind of research that were building the ground. And so you have different kind of scholars coming to do research, and they will do one-time research and leave, and that either leaves the grounds with no infrastructure or system in place to support subsequent research projects. And so another fellow will come and do it, same kind of a project or near similar kind of projects, investing so much and then ending up getting very little out of the research. And so I wanted to give a specific example of one project that started very small, but grew up to become a very sustainable research project that over the years has been able to sustain research in this place. And every research that's done was built out of that. And as you'll see in the next slide, Muhimbili National Hospital, which you see on the picture, is the largest national referral hospital in Tanzania. And the first emergency department in the country was opened about 9 years ago. We see about 60,000 patients a year in this emergency department. Patients coming in are very sick, so we admit about 70% of the patients that we see. And so in 2009, a colleague of mine from University of California, San Francisco, today I call her a colleague, but by then was like a mentor, came in to do a quality control project, a very small project. And that was the inception of what I'm going to talk about today. This project was mainly focusing on standardizing care of patients by using a standardized documentation tool. And in that time, the charting of the patients was on paper based. And so physician and clinician would just chart anything they wish as per the patient on the paper. And so there was no format or there was no standard on how patients are cared for. And so this colleague, Dr. Terry Reynolds, came in Dar es Salaam in 2009. By then, she was a fellow and she was pursuing Masters of Global Health Sciences at the University of California, San Francisco. And I met her back in the days as a junior medical officer. And as you see in the next slide, she then helped us set a standardized chart like the one you're seeing in this trauma. I say, if a patient's coming in with injury, let's use this standardized chart to see these patients. And then she studied this chart to see what is the impact on how we collect the different variables of trauma and how are the physicians responding to this trauma. As the time went on, she realized that the research capacity on the ground was not very good at the time. There were not that many people who could do research. Back in the days, I was a medical officer, and the research training was not very good. So she took up a task of starting to build capacity, and by building capacity, she did it in different ways. Her mission originally was just to do a project for a fellowship and then move on. But then she sat down and decided to say, okay, let's try and make this more sustainable. So she started by looking at things that are important for this kind of research at this place. She quickly realized that by just doing this paperwork originally, it's not going to be sustainable over time after the project is gone. And so she worked out to make sure that this chart is part of the hospital documentation alongside ourselves. She trained me and other colleagues of mine that we could use this chart to abstract any kind of research. And as you'll see in the next slide, she also supported this documentation to be standard across the entire facility, that any patient coming in from different points will receive this standardized documentation. And this standardized documentation will have data points, and these data points can form a registry. And then so the second headache become, okay, then if this is a registry, where do we set up this registry? And they quickly, as you'll see in the next slide, she came up with this idea of using an open source software, RedCap, which is hosted by Vanderbilt University and is available as an institution. And she supported us to set up this one for our registry that can be sustainable. And this was 2009. And eventually, over time, as you'll see, the next slide, we were able to produce different kind of research out of this registry. You will see these 4 projects that have been published in different journals are projects of the local master's students that came out of this registry that was never there before. And eventually, from these projects, other students went on to use this research platform, not only the local students, but also other fellows coming in to do different kind of research projects. We tried to fit them into this kind of I'll say, platform, and make sure that we streamline all kind of trauma registry and trauma research towards this one. This helped us a lot because, one, if you come in with a bit of funding, instead of you setting up a different network to collect research, you feed in into this registry, which is already available locally. And from this registry, then you are able to get the data you want prospectively, and you're also able to support subsequent data collection over a very long period of time by just bringing that infrastructure. And beyond that, this also supported not only research, but multidisciplinary research involving trauma, not only trauma plus other kind of diseases. You will see in the first publication, which was HIV screening in patients with trauma, and the third one, which was on the use of alcohol and illicit drugs. Next slide, please. Eventually, after about 6 years, we were able to collect over 60,000 injury patients. That means about 99% capture. We were able to document how significant is injury burden in Tanzania, especially for the patients coming to the national hospital, with over 50% of patients involved in motor vehicle accident. This injury registry is not only used by us as researchers, it's now used as part of the by the ministry and also the government to take information that is using for its advocacy, for its legislation, and different other policy. But this came out of just very simple quality improvement initiative of a fellow. Next slide, please. Now, you may wonder what kind of support was there from there. As I said, this started by a fellow from University of California, San Francisco in 2009, doing a quality insurance project, very low budget, with no significant funding. But eventually, over time, different partners came into place, and these partners came in to do trauma research. And as for them, since they wanted trauma research, when they came on the ground, we said, well, you have a good research question. We can feed this research question into already existing trauma registry that you already have, and you can support this trauma registry this way. And in a way, you're supporting the local research capacity, but you're also getting high quality data for your study. But also, you are able to come back 3, 4, 5 years after your fellowship with even a bigger project from this one. And so with this study, we've been able to, with those different partners listed there, we've been able to do a number of multiple projects built into this registry, apply for different grants since it exists. And this registry is not owned by anybody at the moment. It's an institutional-based registry, but it's available for any scholar who has gotten a permission to come and do research with a research question. And our expectation is that such kind of a registry will remain and grow to become sustainable over a very long period of time. Many low and middle income countries do not have registry because of resource, because of capacity, because of documentation issues. But this is one of the models that we've tried to set up and are able to use it for now and future. Now, in the next slide, from this local registry, you'll see Dar es Salaam is on the left, on the right corner, as I showed in the first slide. If you click this slide, you'll see the red zone. These are different regions that have started to implement this registry by copying from what we've done here in Dar es Salaam. It's still a lot to be done. In that slide, you'll see there's several different regions, and these regions were demand driven. Fellows came from different places. Some are local and some are international. PhD fellows, master's student fellows, and different fellows wanting to do research in different areas. They approached us. We shared with them our registry plus the REDCap. Some of these places already are putting in data into the REDCap, a different platform. Our hope is that such an initiative can end up having the entire country covered in red, which means every place has a registry that is feeding up to a central system. And by feeding up to a central system, this will eventually form the current and the future data bank for anybody wanting to do trauma registry. And it will also drive research questions from different places related to injury. And because of this initiative, in the next slide, we were invited by the World Health Organization to contribute into the International Registry for Trauma and Emergency Care. The World Health Organization has launched the registry, and so the information we are gathering through this registry is feeding up to this World Health Organization International Registry. And by doing that, we are contributing to the global registry, which is able to compare the trauma we see here in Tanzania and different low-income countries, and also able to gauge different preventive measures that can help prevent injury or inform the care of the injured. And this is very exciting because we're always having a challenge of data that we don't have different data. Now, there are several challenges that we've encountered and the lessons that we've learned through this process. One of them is the number one, which is the core of my talk today, that local research capacity building. I would like all of us as fellows, all of you guys as fellows, to think about whenever you go to do research in a middle-income country, how are we going to sustain that over the future? Because for sure, if you're a global health fellow and you're interested in global health, you're going to come back there at some point or some similar place in the future doing bigger research. This may be a small project now, but think about the bigger future, not just a standalone project. We have several limitations. Obviously, resource is always a challenge. We're doing this this registry that we are doing with very limited budget, and sometimes with no budget. But since the infrastructure of sustainability was built in, we're able to just keep going without an interruption. There's always multiple responsibilities. We are doing administrative work, we're doing research, we're teaching. My program is young, so I'm caught in between administration, research work, and teaching. And so that put a strain on checking on the quality of the data we're collecting. And another one is multiple parallel initiatives. So in the same country, in the same institution, you might find a group of other people, which is what we are trying to deal with right now, putting a lot of resources to try and do the same thing instead of collaborating. And this is always the challenge, depending on where the folks are coming from, meaning institution. You may have an institution like mine partnering with University of California, but another institution up north is partnering with another institution, or south partnering with another institution. And you just meet in a meeting and realize, well, we're doing the same thing. If we could consolidate our efforts, we could get the same thing with different outcome, but with very minimal resources. And with that, in the next slide, I would like to acknowledge these are four guys who we've really worked with in different stages. Dr. Terry Reynolds on the left, and Lee Wallis, Mike Ranyon, and Professor Julie McCanny. Some of you may recognize some of these people. They've been good mentors of ours. They've supported building different registry. And the institutions on the left that we've worked with together to build this registry. Now, from here, we are also now building a sepsis registry and a chest pain registry, which were non-existent before. The hope is these will inform future research and future researchers. And that concludes my introductory talk. I'm happy to take any questions.
All right, thank you, Hendry. That was inspirational. And let's see if we can get some questions and discussion going from the fellows on the call.
Hello. Thank you, Doctor. This is Emmanuel from Uganda. I'm just curious. Did you involve the government? So my idea is like Ministry of Health initially from the beginning of the registry, or you didn't? And then if you didn't, how do you advise for people to work with governments to promote their research? Thank you.
Thank you very much, Emmanuel. To be honest with you, when we started this project, we did not involve the government. This was initially a very small project. But to your point, and you're very right, that as the project grew bigger and we started to have bigger data, we drew interest from both the government and different partners. And then we had to sit down with the government to talk to them about our data and how this fits into the demographic and health surveys of the ministry and how they tap into information for consistency of data. And so my advice to anyone doing this kind of research, always depending on the size of the project, you always have to think about engaging the government, especially the division of either epidemiology, demographic and health surveys. One, because your data is useful if it's going to be used locally by the government. That's not just for publication, it's going to be useful to inform care and prevention. But also two, to just make sure you're not duplicating what is already existing in the ministry, to say the least, so you can complement their work, and also knowing that they will understand you're doing the work to complement theirs, and also you can reciprocally get information from them.
Hello, Henry. This is Nelson. I'm from Uganda. Wondering whether your practice sort of easily spread to the rest of the other departments, besides the emergency department, and whether you got additional support to fund access to internet. We know RedCap requires, I think, uploading the entries. It requires internet, so I don't know how sustainable that was initially, and who helped support that. Thank you.
Thank you, Kalema. It took us 5 years to get the impact of our trauma felt to other departments. As I said in my introductory lecture, the research capacity in Tanzania is not very robust, especially on the medical side. The hospital work with most of the folks, they are clinician and they're good clinician. And so at the moment, yes, the impact of our work is now felt by other departments, and that's how they've engaged us to develop these two other registry. We're sharing our chest pain registry with the Cardiac Institute here, since you are the first point of entry, and also the sepsis registry with pediatrics and internal medicine. As regards to the internet, we had initial funding for the projects that supported internet, and for sustainability, we built in the RedCap towards the hospital servers. And so for sustainability, the RedCap internet is provided by part of the internet that the hospital provides to all the staff. That's how we've been able to sustain it.
Great, thanks.
Sorry, let me ask another question. Is your registry patented? And if not, why not?
Our registry is not patented here in Tanzania. One, because we felt that since we got different variables from different open source, including partly from World Health Organization, we felt to let it be open source, but to access data, you have to have certain permissions to get the data. So anybody can copy any of our variables and use to build their own registry with no any hard feelings from our side. But to get the data from the registry, you have to go through a process of accessing the data. And our feeling is we received a lot of support from other open source databases to be able to build ours, and we felt it should be open to different people moving forward, with acknowledgement to the ones who supported building it from the.
Okay, thank you.
Sorry, one quick one. How consistently is the data collected, and how complete is it or usable? I'm sure it's usable because you already published a lot of out of it. But how did you deal with challenges?
Yes, so initially the consistency of data was, when we started, was around 50%. But then since introducing standardized documentation as part of clinical care, so which means the doctors will write a clinical note on a paper that is standardized, and then a carbon copy of that becomes the registry. So the top part of it is like a receipt book. You write on top of it as a clinician, the downside of it as a carbon copy. That carbon copy remains in the department, and the data clerk enters the information into the registry. That improved our capture to above 98%. We moved from paperwork to electronic medical record 3 years back. That made our capture 100% because now we are exporting the information from the electronic medical record. The 5 regions I've shown which have started to adapt our registry are the ones that are starting to struggle with what we were struggling back in the days. And we believe by giving them a standardized documentation, they will go through the process that we also went through. So those are the challenges, that the clinician will not always give you the right data that you wish for.
Thank you.
So Henry, can you talk a little bit about your academic journey and, going from a junior investigator to faculty, and how that occurred and what kind of requirements locally are needed for that? Hi, Henry, it's Dr. Klausner. Thank you. Are you able to talk about your journey academically, how you moved from a young researcher or fellow to an academic position, and what are the requirements for that?
Thank you very much. Yes, so I feel very lucky to be where I am today. Most of it is by luck and support of great people that I've worked with over the years. I graduated medicine, and then I wanted to do a different specialty from what I am doing today. And I got excited in 2010 when emergency medicine started in Tanzania as a new specialty. And I felt like this is something that I would need to try in and see how it does. And I enrolled in the first batch of emergency medicine residents back in 2010 and graduated in 2013 as a first class. We were 8 of us. And immediately after graduation, I developed a strong passion towards research. I was lucky to get in touch with some of senior researchers, like the one I projected in my last slides, Dr. Terry Reynolds, Mike Ranyon, Lee Wallis, Professor Julie Makani, who by then had done quite a good number of research, and they mentored me to do research. All I wanted to do was to do research. And back in the days, you either had to decide to be a clinician or to become an academician. And by becoming an academic, you are more inclined towards the university, but you also provide clinical care. And as a clinician, you do most of it as a clinician. And since I wanted to do research in the university, the research environment was more supported. And so naturally, I transitioned it from clinical work 100% to do academics, which included research and training in 2014. And became young faculty in the department. And I went through a series of mentorship with different mentors that I've pointed out earlier, and they're the ones who showed me the path. I'll give an example of the GloCal fellowship. I was kind of directed by Dr. Terry Reynolds that since you're junior faculty and you have a strong passion for research, I think this fellowship is very good for you. And taking this fellowship will kind of build in towards you. And I took the fellowship in 2014, 2015, which was like a very big building block towards my current academic and research career. I graduated as a fellow back in the days, and then I was able to continue my research. So the acute presentation research that we do today, I started it in GloCal fellowship and was supported hugely by some of these mentors. And I've used it as a building block towards application of different grants that I'm currently holding that supports my research work. And from there, I realized quickly that I ought to do a bit more on my research academics, and that's how I joined the University of Cape Town to do PhD in emergency medicine. And currently in my third year of that, and mostly doing research. And I must say, in low-income country like Tanzania, and probably it's the same in different other places, it takes a lot of energy and self-dedication to develop into becoming a good researcher. Just because most of the academic infrastructure are not supported towards that. That's number one. But also, there's a limited funding stream for junior faculty. So most of the funding stream that will allow you to be able to do research are highly competitive. And if you're coming from a background where research was not very strong built into you, you will really struggle to that unless you have a strong mentorship support. And I felt that firsthand because without this kind of mentorship and support that I've enjoyed, I probably would not have been able to achieve even a fraction of what I've been able to do. And so it's very important for all of us who are here to consider that as we move forward from becoming junior faculty to becoming from junior researchers, mid researchers, senior researchers, that there's a big need to build the capacity to the locals that you find in low and middle income countries, as the research competing and conducting infrastructure is not the same. That's kind of what I'll say a little bit about my kind of research background. And moving forward from here, I look forward to supporting, and I'm currently doing that. I'm supporting currently about 27 Masters of Medicine students through their research projects. And I'm hoping to mentor different fellows to be able to develop strong passion and interest in research, because most of the time, due to lack of knowledge, many people get discouraged and leave the career trajectory away from research.
And this is Jeff Klausner again. Is your salary at the hospital supported by your clinical work, by your research, by your teaching, or what combination?
My salary is now is supported by my teaching at the university, very small fraction by clinical, and a very small fraction by research. But the majority is by teaching at the moment, because it depends on the project at the time that you are salaried.
And you have ongoing funded research projects supported by NIH or supported by other funders in collaboration with other international scientists? Are you maintaining those collaborations for funding? Let me repeat the question about, are you currently maintaining external research funding through collaborations with U.S. investigators or other investigators to receive ongoing funding, or submitting new proposals to Wellcome Trust or NIH or other organizations?
Dr.
I think you might be on mute, Dr.
Yes.
Sawa. Okay.
Yes, I am currently maintaining those relationships and with colleagues from different institutions in the United States, and we're currently supported by different organizations to do our work at the moment.
Okay, because I think that's an important area, particularly for earlier mid-career investigators, is to maintain those international research collaborations. It becomes a synergy between the local investigator their access to the study population, the relevant research questions and hypotheses, and then the European or US investigators who sometimes have a better access to funding to be able to maintain a robust research program.
That is absolutely correct.
All right, some other questions, comments from the fellows?
I'm just impressed by how something as small as a quality improvement project has grown to become such a huge and important part of healthcare in Tanzania, and I'm inspired to sort of, hopefully I'll get in touch with Henry, and we try to do something like that for our pulmonology unit at Malago. And the challenges we ran into were mostly getting the healthcare workers to fill out the form. It was sort of an additional form to what they already had. And we didn't have so much buy-in from the admin, so it kind of lagged and trailed off later on. But I'm inspired to take it up again and learn lessons from what Henry has just shared. So good job, Henry.
Thank you, and I'm happy to provide any information that may be helpful.
Yeah, thanks.
Okay, well, maybe we should wrap up today's session. I want to thank Dr. Sawe very much for sharing his materials. If you look at the calendar invitation, you get really excellent examples of the curriculum vitae, the NIH BioSketch, the brief bio. Those should be models that people should use as they're working toward developing their own materials for different kind of submissions in the future. So thank you very much, Henry, for sharing that, and thank you for sharing your journey. You provided your email, so if people have any questions, I encourage them to follow up directly with Dr. Sawe via email. And best of luck with all your research and your teaching and your 27 students that you're training in research. That's really exciting. And I wish everyone a good evening and a wonderful day. Thank you.
Thank you all for taking the time.